Okay, let's go ahead. Make host. Okay, so you're now host. Please go ahead and try out your screen sharing.
All right. All right. Everybody see the welcome slide so far?
So far, so good.
All right. And hopefully, let's see if I can make it change now. Oh, yeah.
Oh, yeah. Everything's working.
All right. Then that should be all we need. And I don't know where, I haven't used Zoom in a while. I don't know where my, oh, there's the chat. Okay. So I can leave that as a separate window and I'll stretch that. All right. All right, well, we'll give everyone until about 3 or 4 after 6 because we're not using Google Meet this time. So might take some folks an extra minute to download the Zoom app if they haven't recently.
Sounds great.
Go get it. Got to give the dog a treat. They know exactly what time it is. Good girl. All right, everyone. Well, thanks for attending. We're going to get started with this in about 3 minutes or so. And we have a lot of material to cover tonight. We are going to talk about a little bit of the evidence behind microneedling. We'll just scratch the surface, but I'll give you a good idea of kind of what I have found over the years. And the moral of the story is microneedling is a evidence-based procedure. It is a very impressive medical procedure that works. It works from a microscopic standpoint. It works from a theoretical standpoint. It works from a real standpoint when enrolling patients in clinical trials to try to achieve an outcome. And it should be treated as such. And one of the things I've loved as a provider is I use my experience reading the literature and share that with patients and say, well, you know, in a study where there were a meta-analysis, at least where there were 400 people like you, this is what you should expect. And it's pretty cool to have that information at your fingertips. So hang tight. We'll wait another minute or two, and then I'll go ahead and get started. We'll save questions for the chat window at the end if possible, because I got a little bit more material here than the time allows. So I'm going to try to get through it. I didn't know what to cut, so I'm just going to give it all. At the top of the chat, there is a link, and that is a fully online CME accredited training course in microneedling. And that is something we at Practical CME have offered since 2014. That course is now also paired with some special unique content for the Dermapen 4 that is not in our present course that the general public can buy. So this is a private course that is our full CME course and then has additional non-CME content for this equipment and importantly, the home care products that you need to make sure to properly match with your patient. And so we wanted it to be a good one-stop source where I know a lot of people don't learn well from a book. They want it presented in a different way. So we put it all out there for you. And I think it's going to be really helpful. It's the only CME accredited microneedling course out there. It's been that way for 10 years. And we're constantly adding to it. It was last updated last week, and we will continue to update it. When you do purchase the course, you will get updates for 2 years. You'll get a 3 CME credit certificate, and you will have 2 years of access with automatic uploaded updates during that time. And of course, that special content specific for DP4. So click that link and take a look. Open all the little blue accordion windows so you can see what you're getting. But it's a pretty good course. We've gotten a lot of good feedback from it. So thanks for joining. And I recognize some of the names from the webinar we did 3 weeks ago. And we're going to pick it up with evidence-based microneedling tonight. So if you're skeptical at all about the procedure, say you're not doing it, maybe you haven't had great results to begin with, you've used different equipment, you just aren't really sure if this is for you, then this is the place to be. I am a physician. I am a MD physician. I've been doing aesthetics and wellness now for over 20 years. I was formerly an assistant OBGYN professor at Emory University. I founded Practical CME Medical Training in 2008. We now have a faculty of 6 other MD physicians. We wrote the first ever microneedling and PRP accredited training course way back in 2014, and it is now 10 years old. And we have since split off the microneedling and expanded it. There are tons of links to the medical literature, and every single paper you're seeing tonight, you will get a full text link. If it is published in full text, you will be able to click right on it and read that paper, and I urge you to do so while you take the course. This course is fully CME accredited for doctors, nurse practitioners, PAs, registered nurses. Our credit is AMA Category 1 compatible, AANP compatible, ANCC compatible. So all of these things are embedded in the course. So when you print your certificate online, it will state that, and then you can use it for your medical malpractice carrier, or if you change jobs, to prove that you've had accredited training. Now, I don't know, has everyone out there actually told their professional liability insurance carrier that they are doing microneedling? Just because you have a policy doesn't mean the procedure is covered. And if you haven't, I strongly urge you do so. In some cases, they will ask for nothing, but most of the time they will ask you for proof of training. And often, if you give them a CME accredited training certificate, they will add the procedure on at no charge if you're already covered for other aesthetic or injectable procedures. So it's really important to have that training in place. I have had at least 24 other people who have taken online courses from us in other disciplines that have submitted their certificate and been able to negotiate a discount on their insurance. So it's very important. They want to see CME accredited training. It means you know your stuff. So let's go on ahead and move forward. That's Practical CME and where we teach. And let's kind of get started. And we're going to talk about microneedling in the literature tonight. Earlier papers about mechanisms of needling, clinical treatment outcomes, but also what are the effects of needling itself versus product? And I think this is a really important question as providers we need to answer, because we need to be sure when we send our patients home that they are getting the best results and they are not going home and sabotaging their procedure by either using no product or the wrong product. And so we'll start with the microscopic side of things, and then we'll branch out into the clinical trials. Believe it or not, there are some for microneedling. Scars and wrinkles, which are, of course, the on-label indications. And then I cherry-picked a few for both pigment and vitiligo that I found were interesting that I wanted to share. So microneedling's been called a lot of different things over the years. It sometimes could be just called needling. Microneedling is two words. What you saw in the 90s and early 2000s was collagen induction therapy, CIT, kind of naming it after what the original discoveries microscopically were for needling, percutaneous collagen induction. It was felt that the first example of this type of procedure on scars was called needle dermabrasion. That's the source. And it used a tattooer that had no ink in it to try to make punctures into a surgical scar and soften it. We saw the first micro needling skin roller in 1996. That was the predominant way that people needled in the early 2000s. We also saw stamps, and then that transitioned over to motorized pens in the late 2000s, 2010s, and beyond. Notice I will not talk about, and the course does not address RF needling, because RF needling is not microneedling. It is a second procedure that is piggybacked on top of our traditional microneedling. And also they use depths that are not within our realm of study for microneedling. If I would call it anything, I would call it macroneedling or God only know, macroneedling with energy. But it is basically evidence of a procedure that is trying to hijack the name of something that is well loved and well respected as a conservative treatment, trying to hijack that name and use it to sell expensive equipment. So generally in the 1990s through the early 2000s, most of the papers, and these were my favorite papers, were trying to prove what the cellular response of microneedling is, what is actually happening in the skin when we needle it. And then we started to see more clinical trials where we were trying to achieve a visible outcome on folks. That sort of dominated the decade of the 2010s. Then the pandemic hit, and a lot of those studies just kind of paused or fell off because we couldn't contact people and the such. So we got a lot of junk publishing. We got a lot of review articles and meta-analyses because people just couldn't publish, and they had to. They were in a faculty arrangement, and they had to do something. And so when you search for papers during this time frame, be prepared to sift through a lot of people stating the same stuff over and over again, and a lot of meta-analysis are weak. Now, recently, what we're seeing is some proof of using microneedling with other products, but most of the time when you see the word microneedling, it is not involving a motorized pen for an aesthetic outcome, but it is a patch of something made with little needles in it that is meant to be applied to the skin and remain there for drug delivery. You're also seeing a few papers with RF as well. And one bizarre paper I saw, which actually did use a microneedling pen, tried to microneedle either phenytoin versus insulin for acne scars. I don't know where they came up with that idea, but anyway. So definitely the richness of the literature has somewhat changed since the pandemic, but there's still a lot of good stuff out there, and I'll share some with you. So when you're looking at microneedling as a science, you want to kind of try to separate what's the effect of the channels and what's the effect of the products. And the reason for that is that not everyone's going to use the same product. Not everyone's going to use the same product for the same duration of time. So what is your baseline response that you're getting from the channels themselves? Are you getting anything? And then what can you do with products? Is there a synergy, or is there even something additive or augmented when you use products on top of open channels? And we can answer those questions. Now, I will tell you this, every single study I've shown, including all the studies I'm going to show you tonight, all the studies you can click on in the course, I wish I could change at least one thing in all of them. None of them are perfect. Sometimes I don't like that they used a roller instead of a pen, and other ones I don't like the topicals they used, and some of them they use no topicals. I don't like the depth. I don't like the interval between treatments. The control group is lousy, or there's no control group. But that being said, we can still get something out of all of these. And I'll kind of try to show you how I read and interpret these studies as we go. Also, a lot of these have a lot of bias in their endpoints. Some of the questionnaires, independent observers versus patient observer, there really is no placebo control unless you're doing a split face. But anyway, that's aesthetics for you. You can't get perfect. This is kind of really a lot on one slide, but I call it the algebra of microneedling, and I'm going to show it again at the end as a summary. But basically, what microneedling offers, and I mean, look, this is in aesthetic medicine, this is the only procedure I have where just about everyone that walks in my door is a candidate. No matter what their age is, no matter what their skin type is, no matter what they want, I can do something good with microneedling, and I can do it in a package of 4 treatments or less. And that to me just blows me away. That's why I love the treatments so much. And the reason is if you do microneedling right, you get a healing response that is greater than the trauma from the needles themselves. You get a cellular function microscopically that works better than that patient's age baseline after a treatment. You get more healthy collagen than scar collagen, again, if you do these procedures right. You get improved dermal thickness over and above their age baseline. And you have a safety that's way greater than lasers because you're not using heat to coagulate and damage tissue and create scar collagen. And finally, the most important equation, the injury channels plus the products give an enhanced effect. And so I'll go over some of the papers that led me to those conclusions. One of the things I like to talk about when I'm interviewing a patient, though, too, is there's really 3 goals of any kind of aesthetic medicine therapy. Do you want to slow down the clock? Do you want to stop the clock? Do you want to turn back the clock? Not everyone's a candidate for all 3 with our kind of conservative therapy. Now, with surgery, a lot of times people can turn back the clock, but at a price and with some side effects. That being said, you always want to know where the patient's head is for their result, because as you go down that list, it gets more expensive. It takes more time if it's even doable. With microneedling, you can do all of these things depending on if you pick the right patient with the right pathology. So when you injure skin with these sterile needles and you do it with properly prepped skin at proper depths, you get a lot of growth factors with a minimal amount of injury. So what you're trying to do is get healing without injury. The color coding here basically says the green guys are really, really good. The yellow guys have good and bad, and the red guys are bad. One thing that microneedling does is it really makes sure that there's not a lot of the bad stuff, and that's granulocytes, because those are pro-inflammatory. They can lead to activation of pigment and scar, which is why your average cut or scrape that you don't put Neosporin on, you don't put a Band-Aid on, and you just let heal is more likely to have an uglier scar or pigment in it, because we are doing everything in a controlled environment. But macrophages, monocytes, cellular immunity like T cells, interleukins, interferons, we can turn on all of these things with just a microneedling and without creating a permanent injury, which is amazing. Platelets, it's plus or minus, but epidermal growth factor, transforming growth factor, vascular endothelial growth factor, all of them are very important. In some situations, they may be pro-inflammatory. In other situations, they're not. They have a limited role. Of course, when you're injuring skin, you're injuring small blood vessels, so you're getting those platelet growth factors. It's all part of the response. The Oust paper in 2011 that I'm going to show you here is really important. They took mouse skin and they showed a 140% improvement in epidermal thickness. More importantly, the new collagen that they saw back in 2011 was a loose non-scar collagen, and they even stained for TGF3, which is probably one of the most important growth factors for scarless healing. You see it a lot in infants and babies who have more scarless healing than adults. You got a good short-term upregulation of that. Slide A is your control. Slide B is topicals alone, generally vitamin A and C. Slide C is microneedling alone, and slide D is both. So you can see the most dramatic response deeper below the epidermis is in with the microneedling alone or the microneedling plus products. Again, just looking at control versus microneedling, what they concluded is that there was a tremendous upregulation of growth factors and the appearance of first type 3 followed by type 1 collagen, but the type 1 collagen that then came in was orderly. It did not have a scar-like arrangement where the fibers were parallel and didn't move. But you also got the bonus, and this is where red is good on this slide, by the way, glycosaminoglycan, which is hyaluronic acid proliferation, which makes your dermis thicker, more resistant to wrinkles, and fibronectin, which is important for fibroblast upregulation. All of this you saw just from the needle channels alone, which is amazing. If you were to try to put all of this stuff into some kind of product and sell it in a bottle, first of all, you couldn't. But if you could, and get over all the biohazard issues because you'd have to derive it from humans, this would be insanely expensive. Yet you can trigger this in anyone. The Liebel paper in 2012 is really interesting in that they got down into a lot of the microscopic changes, but they also introduced a fascinating concept about how a microcurrent is generated when you make a channel. And that's due to a lot of rapid movement of sodium and potassium, which then turns on some local gene expression and important upregulation of metallo-melanopropiate, oh my God, forget it, that cause pigment reduction. Never mind. The new collagen in this study was seen at 3 weeks. And that was really good, again, confirmation that what we're doing is the time frame of what we're doing. But they made a good point, and others have the same, that generally the superficial dermis is where you see the changes. Even if you're needling deeper, you're still seeing the changes at the superficial dermis. You can look at Fernandez back in 2008, who was the pioneer of the needle roller, who also said that 1 millimeter versus 3 millimeter needle depth showed no difference in results except for scars. And there was more painful. Also, first person to really recommend vitamin A and C in recovery, and a lot of other studies use that. Of course, we have much better products to use now in recovery afterwards. And of course, the histology was vastly different than post-laser because you did not have the heat effect. Now, I showed this in the last webinar, but just as a bit of a counterpoint, this used a microneedling pen in 2016 and noticed that no matter how deep they tried to go with their channels, they could only get the fluorescein spots to go so deep. And then they also noticed, which was on this slide, that after 30 minutes, the channels started to close to their pigment, although the fluorescein could continue to penetrate. And so that's one of the things I learned from this study, is that you may not be going as deep as you think, and that could be because the pen is not strong enough, although you have a Dermapen 4, it probably is, but you may not be holding the skin taut enough. So there's a lot of different factors involved. So that's why we always teach endpoints, not just depths, because these guys proved, as well as the other ones proved, that you're not always getting the depth that you think. This paper in 2015, one of the last really good papers that looked at microscopic changes, showed a lag time of 6 to 8 weeks from treatment to visible results for wrinkles. We know that from our clinical practice. This person did them too frequently. They did 6 sessions at 2 weeks, 2-week intervals. So we learned from this study that it's just too soon. They did see dermal collagen of all types, but mostly organized type 1 after treatment. Type 3 collagen leveled off at 4 weeks. They did get a skin thickness. What have we learned? Well, some of the things we've learned is that collagen, especially what we've learned from scars, is that we make collagenase when we needle the skin. And so not only do we get production of new collagen, but collagenase increases for a few weeks. So if you do microneedling too quickly, guess what? The new collagen you tried to create 2 weeks ago, you're going to break down with the collagenase response by doing your next treatment too soon. So again, little things that you learn by piecing together the medical literature. Now, specifically with scars, that collagenase response is extremely important, which is why we need to really traumatize these scars more than we need to intact skin, because we need to generate more of that collagenase. And if the skin doesn't get infected and there isn't a significant trauma like you might get with a scrape or a bruise or something else that isn't a surgical grade needle under proper skin prep, you're not going to see that scar collagen. You're not going to see that increased pigment. And you're also going to see a very rapid masking of vasculature. So you're not going to see a lot of prolonged redness from the skin being very thin, because the thicker dermis, the more hyaluronic acid, the thicker that you layer you have, masks that vasculature. So you're not creating new pigment. We'll talk in a minute about how you can break down old pigment, and you're getting more masking of vasculature. So now let's switch over to clinical trials. This is a meta-analysis, which is pretty decent. And they looked at a bunch of different clinical trials, and out of 414 patients, they saw a P less than 0.05 difference in the microneedling groups. And in the studies that looked at RF microneedling, they did not see any significant improvement. This is looking at needling alone versus PRP, and they used a derma roller at 1.5 millimeters. So again, these studies aren't perfect. They're not doing 2024 protocols. They used intralesional PRP, which wasn't activated. PRP should be activated. And so these, after 3 monthly treatments with an N of 55, they did see a better effect with needling and PRP compared to microneedling alone, but both had a P less than 0.01 response. So it doesn't matter. If you want to avail your patients to PRP, you certainly can. You don't have to, because you're going to get good results regardless. Another one from, this was published in 2024, PRP alone. Just wanted to find a few real recent ones. PRP alone versus microneedling with PRP. Again, they didn't activate the PRP. That's the problem. They only injected it intralesion. They should have used it topically and needled through it. In fact, a lot of these studies don't use their topicals before the needling and needle through the topical. They only apply it at the end, and who knows how late they waited to apply it. Anyway, despite all the problems, after 3 monthly sessions, the microneedling group did better than the group that just got PRP injections alone. So if you've got acne scars, you've got to microneedle. You know, in my opinion, it is the gold standard now. Whether you want to add PRP or not is totally up to you. You can take our training course and we'll show you how to add it quite easily. Looking at surgical scars, this is a randomized control trial for post-abdominoplasty scars. And I liked picking out this one because they actually used the Dermapen 4. The problem is they didn't use any of the serums that came with it. They used cetomacrogol, which is kind of an emollient, which kind of is something really I would not use after microneedling because it kind of generates an oily layer on top of the channels. That being said, if you look at the treated versus the untreated side, and what you want to see are blue lines. You want to look for the blue line that is longer. And in all aspects, color, stiffness, thickness, irregularity, and overall opinion, microneedling did better on post-abdominoplasty scars versus the control of just topicals. Want to switch briefly to melanocytes. As you know, that can be frustrating, but if you have patients who stick with their needling long enough, they get a really nice result. And remember, aging is the down escalator of life. Every day you go out and get in the sun, everything's just going to keep getting worse. And so if you stand still, you're going to hit the floor on that down escalator. So if you want to stop the clock, you got to turn around and walk the other way. You want to turn back the clock, you got to turn around and run up that escalator. And so with melanocytes, that's definitely the truth. And that's going to mean a lot of repetition. So if you want to fix pigment, you have to, of course, block ultraviolet light. And I've just listed a few products that work to do that. Of course, sunscreen being the main one. You got to inhibit tyrosinase. You've got to try to disrupt the formation of the melanin molecule. You've got to disrupt the transfer of melanin to the keratinocyte. Why is that red? Because that is something microneedling channels have been proven in the literature to do. Suppress melanocyte stimulation hormone, and finally, improve epidermal turnover, because the more epidermal turnover you have, the more likely you're going to get new keratinocytes that don't have pigment in them that are replacing ones that are storing pigment currently. And there's a lot of things for that, but microneedling is, again, one of the best ways to do it. And this is just looking at dry needling. Everything that you're putting in those channels is going to light up all these other parts of the process. And that's what the home care regimen is all about. Looking at a couple of clinical studies now, Bailey in 2021. Again, this is a review, 12 studies, 459 patients, looked at topical versus microneedling, and showed that needling plus topical therapy showed a significant improvement as soon as 8 weeks. I do kind of tell my patients with pigment not to see improvement until month 3 or 4. But if they do see improvement at 8 weeks, like this study goes, then that is a nice benefit. Now, this is something I learned prepping for the latest edition of the course, is we have seen some papers supporting microneedling for vitiligo. Now, I don't see any vitiligo patients in my practice, but I'm going to start trying to recruit them. And I love this comparison here, because you've got 2 papers that tried to do the same thing, but had one aspect different, or a couple aspects different. But the microneedling alone part in the top paper, which only had an 18% response, was derma roller, the microneedling, and it was too superficial. In the second one, look at this response from microneedling alone with no chemicals, 56.5. They used a Dermapen. They went deeper and their needling was more dense. And so subtle little differences in these studies can make a real big difference in results. So a poorly designed study that even shows some kind of significant result is still great, because you know if you do it right, you're going to get even better. This one just recently published is a 20-patient randomized clinical trial, 12 treatments over 6 months. They compared microneedling with PRP, erbium YAG laser with PRP. Like, where's the control group? I don't know. But you know, again, problems. I don't know why they thought PRP should be in all the procedures. That doesn't make a lot of sense to me. Anyway, both treatments had significant group. But the erbium YAG laser was a little bit better, but the microneedling group still had an 80% response rate. Now, I'm not ready to go out there and tell someone with vitiligo microneedling is the gold standard, but an 80% response rate, and I don't need to own a laser, and they don't need to pay for a laser, and they can get other benefits, or maybe do their vitiligo, isolated vitiligo spots at the same time we do their face. That might be worth it. And it's just an example of one intermediate outcome from that paper. But you got to love microneedling. I mean, everybody's a candidate for something. So to kind of summarize, microneedling microscopically does some things in the short term that I think are really, really interesting. And that short term could be looked at 72 hours when the channels are open. You have the synergy with the products you're going to use, and that is really important. And your patients need to hit their mark with the right home care regimen done at the right times of the day for the right duration. You're going to get faster epidermal turnover. You're going to get keratinocyte stimulation. The old keratinocytes that are storing up melanin are going to start to disappear. You get release of growth factors, collagenase, type 3 to type 1 collagen, but you're going to see more type 3 collagen from a microneedling than you will from another type of injury, which generally results in a higher pliability of the healing rather than scar. More glycosaminoglycans, so you're going to have more hyaluronic acid permanently in the skin, not just coming in through your channels. And then, of course, long-term, you get this cyclic dermal remodeling. You just have to give the skin enough time to heal in between the treatments. You can't be in a rush with this. Again, back to the algebra. So all of these things are doable with your microneedling pen and the right products for the right patient. And there are dozens and dozens of more papers, you know, we talk about in the course, but I just picked a handful of them just to share with you, and how we kind of pick them apart and try to draw conclusions out of them. But I do want to leave you with the whole clock analogy again. because patients are going to be happy if you exceed their expectations. And in that first visit, when you have a knowledge of what the medical literature tells you is possible, and you have the right tool in your hands, then you can give that patient an expectation that you will meet or exceed, and hopefully you will sell them lots of other aesthetic procedures, and they will refer lots of friends to your practice. And that's what makes doing this really fun. That's the link that is in your chat if you want to look at more details about the course. Anyone who either has the course or buys the course, the $300 off coupon for other things we train in, like PRP, Botox fillers, PDO threads, sclerotherapy of the legs, that is $500 through this Friday. So that discount code is mentioned in the course. Other than that, that's what the link looks like. That's all I had. Sorry, I ran a few minutes over. I ran over our question and answer time, but I just couldn't cut anything out of this. And I will practice the pronunciation of MMPs in front of the mirror before I go to bed. Anyway, let's see. Let's see if we have any questions. DP Derm mentioned one of the studies in the back. Yeah, the product was rubbed in after the needling, not as a glide. And so the depth may not have been as precise, right? And so many of these don't use any product at all, don't use it as a glide. And so you know you're going to get better results when you do everything properly. So that's pretty cool. Anyway, let's see. How long do you use sunblock after the procedure? I recommend folks use sunblock for approximately, well, really, you should use it your whole life. But I want you to definitely use the DP sunblock that comes in the starter kits that we use, at least until the microneedling channels are closed, which is going to be around day 4 or day 5. But frankly, they got to get into a habit of using a compatible sunscreen all the time. I just would rather them use the DP4 sunscreen because they're less likely to create irritation in the needling channels, which could lead to more scar collagen and more pigment afterwards. All right. Let's see what other questions we have. Not much. Wow. I answered everybody's questions. Incredible. All right. So again, I went through it really fast. Just remember, when you do get the real course, all those blue links will be clickable, and you'll be able to look at the study. You can also email me directly. Everyone who does our online courses can email me directly, and I'll usually answer within a few hours during the week and within a day on weekends. And so from that standpoint, we can have a nice conversation about either a specific study or about a particular patient you've had through email going forward. But we're always supporting you afterwards. And I've learned a lot from the people who've taken our video courses for the last 15 years. We've made a lot of improvements in them from their experience as well. One other question: is 24 hours enough for patients to start wearing makeup? Is it better to wait 72 hours? So if they have a makeup that is compatible with microneedling, they can wear it the next day, but that's usually only going to be mineral pigments. Ideally, 72 hours would be best, especially if they have pigment. That would be ideal. So a lot of my patients do plan their schedule around microneedling so that they can chill out for a weekend and just wear sunscreen and not wear a lot of makeup if they need to wear their makeup to work. But yeah, so mineral pigments and things that don't have artificial colorings and perfumes, humectants, emollients, a lot of stuff we talk about in the course, I'm going to allow in small doses on day 2, but I'd rather not if possible. Any other questions?
I think just as a small follow-up to the makeup
Sure.
question,
Yeah.
it's also really important to ensure that your patients are not using their old dirty brushes and applicators if they do choose to wear makeup, because a lot of them just simply don't realize how much bacteria is living on those things. So just always make sure that they understand the risks of utilizing products that they've had for a while that may be contaminated, as well as applicators that may be contaminated, because it can be a big source of infection.
Yeah, that's a really good point. And the other thing is they don't need to be doing any kind of maybe with the exception of acne patients, active acne patients, you really don't need to be exfoliating because you've really had one of the ultimate exfoliations. You've had all these microchannels and have these tiny little islands of stratum corneum that are ready to flake off. You don't need to be using the scouring pads and little rotating brushes and all of that stuff on your skin. I mean, just wash and you're going to exfoliate just fine for the week after this. So I hold anything that could potentially be either a chemical or a mechanical exfoliant while the channels are open. All right. I don't see any other questions. Of course, if you have questions down the road, you can always email me. We'll be doing another one of these, and they'll send an email out, I think, in 2 weeks. Safest step for melasma. Last question. We talk about it in the course, and the safest step for melasma is going to be where the melanocytes live. And that's going to be determined by your endpoint. And so melanocytes live at the bottom of the epidermis. That's pretty shallow. So you're going to use a depth that is targeted to be at the top of the dermis, bottom of the epidermis, but then you need a visual endpoint to confirm that. And we show some pictures of what those different endpoints look like. And you want the pinkest endpoint for melasma because that's the most superficial endpoint. You don't want deep red with a lot of pinpoint bleeding because you've probably gone too deep. And again, if you go too deep and your main target is melasma and nothing else, then you run the risk of there being microinfections or other issues in the post-op care that could then trigger melasma. All right. Peels after a treatment, that's totally up to you. I don't use them. I'm all about letting the skin exfoliate naturally for those 3 days. And I like to just kill the skin with kindness. And that is the hyalactive mask or the bright light mask, depending on whether it's general purpose needling or pigment needling, and lots of vitamin serums, hyaluronic acid, and cleansing and sunscreen. But no peels for me in the first 3 days after treatment. All right. Thanks a lot, guys. Enjoy the rest of your night, and we will talk again in a couple weeks. Bye.